Hello there. Welcome to the Nature of Work podcast. Since the dawn of time, humans have engaged in what we call work. In the modern world, there are thousands of professions: a plumber, city planner, artist, project manager, fashion designer, firefighters, and thousands more. In this podcast, we want to explore the nature of work through the eyes and ears of such practitioners. What got them into it? What is interesting about it? How do they keep up as well as advance? Why is it important? And how their careers have evolved. We hope it is useful to you in whatever career stage you are. Welcome to another episode of the Nature of Work podcast. Today, I'm delighted to welcome Karishma Gupta, that I have known for over 10 years now. When she went off to school or college, we missed our interactions with her. But this gives me the opportunity to connect back and find out what she's been up to, because we have heard good things, and I wanted to talk to her about those. And it was a great occasion to attend her wedding in Seattle and partake in the celebrations. It was such a delightful wedding, and I hope that Karishma is enjoying her wedding career. So, Karishma, welcome to the show. So, as we start with, right away, tell us a little bit about yourself for the benefit of the podcast listeners, and please feel free to share whatever highlights you've been up to.
Thank you, Krish. I usually say Krish Uncle, but for the sake of this podcast, we're going to keep it professional. Thank you. Yeah, it's been a while since I've been in Seattle. I was born and raised here. We've all been a part of the same Indian community, so it's great to circle back as an adult and talk to people, going from diapers and painting and artistic activities like Bharatanatyam to being a full-fledged adult that has a career, carving my own pathway, creating my own paths. I think the last time that we really hung out before I headed off was after high school. I decided to pursue a career in biomedical engineering. Medicine was something that I always gravitated towards. I really like the idea of helping people. My whole life, I've always been intrigued by the human body and anatomy and contributing to society in that manner. And I thought the closest way I could get there with a strong background in math and science was doing biomedical engineering. So I did go to a fair at the University of Washington, and that's kind of what kickstarted this whole process. Was I saw these young college students making these amazing devices to help out doctors and patients. And I thought, hey, why not? Why can't I do this with my time too? And so when I was applying, Georgia Tech came on the radar as one of the top 3 institutions for biomedical engineering. And lo and behold, once I applied to college, they offered me a near full ride to college. So with that little inkling in the back of my mind that I perhaps want to go to medical school and might fall into a lot of debt, my parents advised me to take that money, take it and run, because that's privilege. College can be very unaffordable to some people. So it was the best advice they gave me, best guidance they gave me was don't be stupid, take that money. It's a top 3 engineering institution in the nation. And I'm so glad I did that. Georgia Tech is an amazing institution. Every single building is a different engineering discipline. And I don't think a lot of institutions have that. While I was there, I worked on projects with Emory University, which has a large medical center.
Yeah.
And as I started speaking to physicians and exposing myself to the MD side, medical doctorate side of medicine, I realized what I really wanted was that patient interaction. I liked the idea of me doing something or diagnosing something and seeing that direct impact on people, which I don't think engineering had for me. So I decided to transition and apply to medical school. I did take a gap year in between to carve my path again, kind of restart, refresh from engineering, because I was pretty burnt out after 4 years of biomedical engineering.
Yeah.
And so when I started applying to medical school, I also did a Fulbright research year in India, living with my grandma. and learning household recipes and also studying tuberculosis and the spread of infectious disease.
Uh-huh.
And during that time, I got accepted to Wake Forest, and that kind of kickstarted my way into medicine. And throughout that path, we can talk about it some more during this podcast about what led me down this path. Eventually, I chose diagnostic radiology, which is quite possibly the most perfect career that I could have found. And there are lots of reasons why that we can go into.
Okay. Wow, that is quite a journey until you landed in radiology as a maybe like a full time, or making this a decision to make this your career. That is excellent thing. Yes, we will go through your profile or your bio during the podcast. But this is a great start. Thanks for sharing that information.
Yeah.
So, anything else to talk about your profile, or shall we head to other topics?
I can talk more about radiology, or I could. It's kind of up to you. Whatever you want to focus on, because as I said in my email, yeah, I can speak about diagnostic radiology until you're tired of me.
Okay, no worries, no worries. So, I always start out by asking, what was the motivation to make your choices? You said you're a full-time radiologist now. Why did you feel you made the right choice?
Yeah, I think it's hard when you choose a career at first to know whether or not you picked the right route. And I certainly had a lot of doubts along the way, especially starting out in training when you have absolutely no idea what you're doing. Fake it until you make it is not something people like to say in medicine to patients, but that is quite honestly how you start. Yeah, you have a big hill to climb up. And so there were certainly moments at the beginning of my training, and certainly less so now, but does happen, where I question if I've chosen the right career. But I think more often than not, I've had better days than worse days. And I feel energized after a day of diagnostic radiology. I find it really exciting. I like dissecting through imaging. So we have a lot of different imaging modalities, from magnetic resonance imaging, ultrasound, CTs, CAT scans. And then we have things like nuclear medicine, where we actually use radio tracers and radiation to find cancer. And I think the fact that we have so many different modalities, the human body has such beautiful anatomy, and then using that and using your expertise as you hone in on your skills, you can really make a difference in people's lives. You find things that nobody else can find, and that can change the management of a patient. It can give a patient an answer to why they're in pain or why they have certain symptoms. The idea that I feel like a patient advocate on a daily basis, I think that's what I bring home every day, that really makes this a fulfilling career.
So what do you think you'll be doing in 10 years?
Honestly, I think I will be still doing radiology. I'm hoping I can transition to a place where I, see high acuity level care, complex care, and also teaching. I really do like the idea of passing on knowledge to trainees and also learning from learners, because you only know the material as well as you can explain it.
Yeah.
And when people ask you questions that you have never thought of, that's how you increase your knowledge.
So possibly expand access to radiology globally, in more places where they have no access today. So we can do something for the world to become more, have access to these technologies, and they can help improve the health outcome.
Yeah, absolutely.
For the world, right?
Yep.
That's something that I envision could happen with technology advancement.
Absolutely.
So having said that, you had mentioned that your parents were key in your decision making. Anybody else that comes to mind that was key to making your decision to pursue both this biomedical engineering as well as this career in radiology when you were in that phase?
I had a few doctors that I shadowed in college. The first big mentor that I had was in high school. I decided to take up a research project at Fred Hutchinson Cancer Research Center. And it was through one of my high school friends who was working in that lab that enabled me to start doing lab bench work. Dr. Jerry Radich is quite well renowned in the leukemia world. And what was so amazing is that he actually was one of the many founders who did clinical trials on a life-changing drug for a specific type of leukemia. So he is really well known, a bigwig, as you would say, but still took the time to talk to me, still took the time to train me, and found a position in in his lab for me to start practicing and starting my science career. He showed me that type of grace and understanding that I hope to have in the future as an adult doctor who might be far away from my training years, but I hope to remember what it's like to start out and know as little as you do when you first start out. The other person who's quite influential was Dr. Carol Gear. Funnily enough, she was a neurosurgeon before she went back to residency and decided to do a diagnostic radiology residency, and now is the program director for the residency at Wake Forest. She was one of the few female radiologists that I met at my medical school. There were not a lot of females in radiology.
Is that right? Because every time I've been to them, I don't see a single male.
So the people that you meet in the MRI room are the technicians, so the MRI technicians. They're not the radiologists. The people who are actually the doctors are in the workroom in a separate place. So you don't often meet us. We're a little hidden, I like to say. But I've noticed it's not as bad at University of Washington. They try to keep it 50-50 because they're such a big university.
Yeah.
They have great recruiting power, but that's not true for a lot of places that practice radiology. So the fact that I met a female radiologist who did neurosurgery and then had the guts to go back and do training all over again, and now teaches and runs the residency program. She was a great inspiration. I met her the second year of medical school, and she was probably one of the biggest advocates and the biggest pusher for me to go into radiology. She got me into the reading room. She got me in research projects with other radiologists. She got me that early exposure that I think a lot of people who are pursuing any career don't have. And it's hard to find those opportunities. It's hard to find someone who will give you that time and will give you that effort to get you set up for a career that you're trying to test out without any risks. And this was quite literally just like an open interview for me to be able to experience radiology before I committed.
Got you. So how many hours per day do you work typically?
So I have conference at 7:30 in the morning, and then I end around 5 o'clock.
And is that consistent across weeks and months?
No. So there are some weekends that I have to work, and those are usually 12 to 13-hour shifts. So it would be a morning shift or an evening shift. And then there are some months that I have to do a month of nights straight. So that would be 7 p.m. to 7 or 8 a.m. So it really depends on since I'm a resident, I don't control my schedule as much as I would as an attending, but it just entirely depends on what the hospital needs. And we are the people that work the most in the hospital. I think every resident would agree with me on that.
Got you. I hope all those hours you put in now will pay dividends in the near future.
Yeah.
Do you feel a sense of fun in your workplace?
I chose radiology for that reason. We have the most fun in the hospital by far.
Lucky guys.
By far, yes. I think we always have a nice screen on the side that's live streaming the San Diego Zoo or a cafe in Europe, just to give like a nice relaxed vibe. There are always great intellectual conversations that happen, but also the attendings and residents know each other, ask about our families, how the kids are doing. So it's a very close environment. We're a very close-knit group, I would say. We meet in and outside the workplace. And I still, to this day, say radiologists have the most fun.
Did you know that going in, or you're discovering slowly that this is really a fun place?
I think they market to be a lot more fun than it actually is. So I think as an outsider, you see like the music that's being played and, the live stream zoo, and you're like, oh, this is a great place. But once I finally got to the desk where I was interpreting scans, I don't think I've ever been more exhausted from thinking so much. We're constantly, our brains are on thinking about what are we looking at? what could this be, going through the chart of the patients, talking to clinicians, figuring out what's happening with the patient. So, we say work hard, play hard. I think that environment is there. We have to conscientiously take breaks and enjoy the environment around us. Otherwise, I don't think I could get through the workday.
So, in this field, especially in a field like medicine, there's always a chance for making errors, right? Making mistakes.
Yeah.
What do you think the workplace makes mistakes? Have you made any? Have you learned anything from those?
Yeah, that's a great question. When you're in training, the environment that they have around you is to enable you to be able to make mistakes in a safe environment. So obviously we're seeing some conditions for the first time ever as a trainee, and I have 100% missed things. I have missed things that could potentially kill patients. And the great thing is that we have a safety net. Our attendings are there to look at the scans after we look at them and make sure to point out our mistakes. In terms of pointing out the mistakes, all the attendings have been really understanding and great. They always treat it as a learning opportunity for us, and it's never a point of shame. Though I do think having that onus on yourself to motivate yourself to take every mistake as a learning lesson, so that you don't make that mistake a second time or a third time. I look at places on scans that I've missed in the past. So, if I've missed like a giant blood clot, for example, I know to look in that same place again. So each mistake is a learning opportunity that makes sure I don't propagate that mistake going forward and makes me a better radiologist.
I see. Have you ever had your work paused for any amount of time because of any mistakes detected? Do they want you to take a time out? What is the general approach around handling mistakes? Does it get escalated? Does the community know about it? Share some insights, if you will.
As a trainee, I think we're pretty insulated to the medical legal system. I have heard of cases where trainees are named in medical legal cases. An attending would probably know better about the consequences of mistakes. From my level, whatever mistakes I know is because they've been caught by people trying to train me, and so it's the mistakes are corrected and then also communicated to the clinical team. There are cases that lead to errors that can be life-threatening or life-changing. And that is the current state of medicine affairs in general. Is like the United States is a very litigious environment.
Yeah.
So we try to do our best, though. In radiology, you have to balance accuracy with efficiency, because as we keep getting older, as people are living longer, as we know more about medicine and diseases, people are getting more and more scans. And so it's not a justification to spend too much time on one scan and delay the care of a patient. You have to have a balance of being as accurate as you can with one patient and making sure that you have enough time to dedicate towards another patient and their care.
So as a trainee, you come into situations where you're not able to figure out the case.
Yeah.
So when such a situation happens, what is the escalation process? How long does it take for you to know an authentic answer and balance the conflict between patients decide to know as quickly as possible versus doing the right diagnosis, right? I mean, I've had instances where I'm like, hey, give me the thing right away. But I also know that, it takes time to do the right thing.
Yeah.
So have you been in situations where such escalation needs to happen, and how your organization handles that?
Right now, it's all through phone calls. So radiologists are the doctors, and a lot of the management of patients is dependent on what the radiologist says and when their results are released. So when I'm on call, there is quite a bit of pressure to read in a timely fashion, especially if somebody's sitting in the emergency department, it's a high cost environment and a high resource environment. So if a patient needs to be released to allow another patient to come in who might be a higher acuity, they need the radiologist to read in an efficient manner to make sure that everyone's being appropriately managed. Part of the joke of being on call in radiology is you have so many phone calls that you don't have enough time to read the scans that they keep calling about, which I think is ironic. So there have been instances where doctors have called me asking for what they call a wet read, which is looking through the scan and just telling me what you see on the spot. And for the most part, I try to manage that by asking if the patient is actively bleeding out, or if they're in a really high acuity situation where my read on the spot is going to make a difference. Because what happens is when you rush me to make a read on the spot, I miss a lot of things. And then I have to go back and correct those mistakes.
Right.
And I would say most doctors and most colleagues are really understanding of that. I've had some situations where it gets a little tricky. The great part about radiology and my department is that I feel like my attendings are always on my side and my advocate. So if I ever fall into a place where I feel uncomfortable with how an interaction is going, I have people who are at the same level as the person calling me to communicate things and advocate for me if I feel overwhelmed or I feel like I can't address the issue. So in terms of the hierarchy and in terms of reaching out for help, we're on call in the senses that we have independent call, which means that we're making the interpretations ourselves and doing a preliminary result, and those results are actionable. So if we say something, it is quite possible that somebody out in the hospital will do something and intervene based on this finding that we make. But if I feel like I can't come up with this diagnosis, and I think that this is something that could change a patient's life, I have an attending to always call, and they've always had the time to talk to me and consult and teach me.
Yeah.
It is part of their job as well, description, to make sure that we're being taught and trained. But they're so gracious about their time. They always make sure to carve out enough time to go through studies and answer all the questions that I have.
Gotcha. That's very fascinating. We have this thing called weekend. I hope you know about that, right?
Yes.
It's always more stressful to plan the weekend than the weekdays, right? Weekdays are structured.
Yeah.
You know what you need to do. So what do you indulge in to have nice weekends? What's your passion?
When I do have weekends, yes. So there are some weekends I have to work. The weekends that I don't work, I know those in advance. And my husband very much knows this because he is a last minute planner and likes to do things spontaneously. And I tell him, husband, I have my schedule for the whole year given to me on one day. I know exactly what weekends I'm free. We have to plan this. I can't do spontaneous. So that's always been a little bit of a tension point in speaking of marriage between two people, the planning situation. I am so happy to be back in Seattle. I have a lot of my childhood friends here and people that I grew up with that I'm reconnecting with. We do board game nights. We do Bollywood nights on the week, mostly on the weekdays, and sometimes on the weekends. I actually weightlift and do CrossFit. So that's how I stay mentally fit if I keep my body fit. That's my philosophy. I've noticed every time I skip a workout, I just don't think as well as I usually do and don't have that sense of clarity while trying to plan my day. And so I try to incorporate any type of physical activity, whether it's going on a walk outside, going on a hike. I love to hike with my mom, who quite honestly hikes more than I do right now. She's put me to shame.
Absolutely.
Yeah. But yeah, I like to stay social and I like to stay physically active. There are a lot of other things. I think I'm pretty versatile in what I like to indulge in. I love to eat. I'm a huge foodie. So I like to plan restaurant outings with friends, family, the husband. We like to try new restaurants and frequent our old restaurants as well that we love to eat at.
Yeah. Hey, that's really nice to hear. So, hey, let's take a break for 2 to 3 minutes here.
Yeah.
While my sponsor Jai Shri Krishnan, makes me some chai. Okay, I think the chai will be ready. So I will come back to you after consuming some chai.
Yeah.
And we'll resume this lively conversation, go a little bit more deeper, and see what insights and interesting stuff you could share with us.
Yeah, absolutely. Can't wait.
All right. See you on the other side. Hello, ladies and gentlemen. We are ready to resume our discussion or a podcast with Karishma Gupta. As I said before, she's a training radiologist at the University of Washington. Now, for our listeners, tell us about a little bit more about the science of radiology. I mean, like, they put they have a device that scans. What happens in a scan? Can you for our listeners, what is the scientific principles that or underline, for example, an MRI?
Yeah.
How does an MRI work?
It's a very complex question, and we actually have radiology physicians consult radiology physicists. So we have resident physicists who actually help us with our MRI machines because it's a very complex machine. For an MRI specifically, it's called magnetic resonance imaging. And so it uses a superconductor magnet to actually create signals using protons because protons are charged. And if you change the magnetic field, it can flip the signal. And that's what creates all the imaging theories that we have. So we have things that give us fat signal, things that give us fluid signal, and that's all dependent on the characteristics of how many protons are in that type of material. That's a very simplistic explanation of what an MRI machine does. It's very complicated. I'm studying for my boards right now, and part of my study material includes trying to understand how each device works. We have a lot of different modalities. We have ultrasound, which uses ultrasound waves to create images. Those are all in grayscale. We have computed tomography CTs, which use X-rays in a 3D dimension. So we've got the radiographs, which are the X-rays, and then we have the CT machines, which create the 3D models that we look at. And then we have PET imaging, which uses radio tracers and cross references it with oftentimes a CT scan or an MRI scan to localize high metabolic rates lesions. So if they pick up more glucose, or the newest one is picking up a certain hormone that we see in prostate cancer. And what's neat about that one is we can both use that to diagnose prostate cancer and treat prostate cancer. And it's shown to go from stage 4 all the way down to stage 1, just using that hormone.
Yeah.
And I think that's all the modalities, unless I'm missing something else. Mammography is also X-rays that are stacked onto each other so that we can scan through the breast tissue. And it's a bunch of slices that look like X-rays that are stacked together and help us find breast cancer.
Gotcha. So looks like there has been a lot of innovation.
Oh, yeah.
The last 50 to whatever years in the medical field for diagnosis, right?
Yeah, absolutely.
And what, in your opinion, what gets used the most often? Is it MRI? Is it CT scans, or is it dependent on the type of stuff that the patient comes in with, and who gets to make the decision as to which modality to use?
That's a great question. As we go along, so just to give you an idea, stepping back a bit, my attendings who are currently teaching me now, some of them used to read X-rays and CTs with the light box. So it was a light bulb behind a screen, and then they would put on the actual physical film and read out the images that way. So these physicians, these radiologists, have gone from that to our high level of processing center with a PACS system and being able to dynamically window images to be able to make better diagnoses for our patients. So you can imagine this kind of growth And along with that, radiologists having to be dynamic and life learners to be able to understand all these different modalities and how they change it over time, and our technology and how it changes over time.
Yeah.
The clinicians who order the scans are the ones who determine the modality. They can consult with radiologists and oftentimes do to ask us what the best modality is for a certain type of diagnosis. The one that gets used the most, I would say, are X-rays and CTs because of how quick they are. Our CT scans can scan through the entire human body in one breath hold, compared to an MRI machine, which may take anywhere from 20 minutes to an hour to complete. So just because of the time scale, depending on the acuity of a patient, it really depends on all that.
Got you. Interesting, triaging process. And, it's something that you have to do on a case-by-case basis. So you don't want to take too much time to decide on that because then, that delays things.
Absolutely.
Right? Yeah. So once the scan is started, actually before that, describe to me your workplace. Like, is it like a big building? How many people work there? Is it like, does everybody work there? You said like some people are physicists, or are they in the same building? I think an idea of how an organization is built will tell us a lot about anticipation. What do they anticipate will be the key things driving forward, and expansion and stuff like that. So if you have an idea of how your organization looks like structurally, that would be useful.
Yeah. So because I'm at an academic university, we have all of our facilities basically built right next to where the imaging modalities are. And those tend to be at the center of the hospital because, as you can imagine, the best way to diagnose what's happening to a patient is imaging. So we are as close to patients as we can be. Oftentimes it's in a central area of the hospital. At Harborview, we are in the emergency department at the center. So all the facilities are kind of built as a ring around the reading room. But because we have to think so much and because we're so busy, we're quite insulated from all the chaos that happens in the emergency room or an inpatient facility. So I don't see a lot of patients unless I have to do procedures or if I have to consult them on contrast, allergies, anything like that. And the joke is radiology and pathology are like the basement squirrels. We're a little hidden away in little nooks around the hospital because all hospitals are structured to look really nice wherever patients can see it. So all the patient facilities, the waiting rooms, we like to give more to patients, but that means that they take more and more space from physicians. And so our back areas are not as nice as some of the patient-facing areas. And that's a joke that we're used to, like we're aware of it. And especially being at an academic center like University of Washington, the money is tight, and we want to invest it in proper areas.
Right.
So we have things called reading rooms. A lot of them are stationed right next to the scanner that requires the most attention, whether that be a CT scanner at Harborview. At Fred Hutchinson, we're near the MRI machine. So it just depends which facility we're at. We have. It almost looks like a big IT center. The joke is that I told my dad wanted me to go into computer science. I told him, I don't think I can imagine a career where I'm sitting in front of a computer all day. And where am I at? Basically in front of a computer looking at images all day. So we have these really nice desks. We have really nice, high quality FDA approved barcode monitors, which has to be signed off by the FDA to be able to look at images, have a certain pixel ratio. And then we have one or two screens on the side, one to dictate what we're seeing in a report and the other to look at the patient chart. We have standing desks so we can, not get deep venous thromboses by sitting down all day.
Yeah.
Oftentimes the room is windowless. I'm really not selling radiology, I know.
No,
But this
you're
is the
not.
reality. I mean, it is the reality. Is we don't see outside. It has to be a certain lit room so that we can be accurate in our diagnoses.
Okay, so the patients get premium space, and you guys are working in basement scenario. Hopefully that changes. But does the quality of the workspace influence the quality of your work? Do all days look the same, or are there variations in how you operate based on your workplace thing, your workplace environment?
Yeah, I think that is a really great question. So every month I rotate at a different imaging, either imaging modality or body part, which means that I'm oftentimes changing my environment on a month-to-month basis. It's even wilder for attendings that work at the University of Washington because some of them have to hop to different facilities on a day-to-day basis or an every other day basis. We don't have assigned desks, which means that you don't get to pick your favorite spot. Some of the desks don't rise into a standing desk. Some of the chairs are broken. And I do think that can impact the morale of the people working in the facility, because you've spent a lot of time and money into coming into a career, and to not at least not have the facilities that you need to be comfortable, so that you're not thinking about all of these other cumbersome things. Can be discouraging at times, I would say.
Right. Have you come across any situation where somebody makes a mistake and cites a lack of tools or a lack of comfort in making that mistake?
I think radiologists are very adaptable. So I don't, and a lot of it is we don't like to blame. We're all type A personalities, and we tend to not blame the environment when we make a mistake. At least that's my tendency. Is I tend to attribute it to something that I did. Maybe that will change over time. I think something that in the environment that could impact my accuracy would be, the pressure to read fast, especially
Read fast.
Yes. So when we're short staffed, when there are more physicians on vacation, or simply we just had more people quit, especially during COVID. We had a lot of people quit at the University of Washington and go to teleradiology jobs or go to higher paying jobs. We had a huge shortage of physicians, and some of the cancer staging didn't happen. Their scans didn't get read for 6 to 8 weeks, which is not ideal for anyone who's dealing with the chronic condition. So I think it's less about the facilities and more about the condition of the department that can affect our quality. Obviously, I want to spend as much time as I can on scans for my patients.
Yeah.
I think about every patient as somebody who might be my mom, my dad, somebody I love. I want to give them the justice that they deserve. They're paying for this scan with time and with finances, and anything that I can contribute to their care, I think is valuable. But when I have pressure on the other end from other physicians or the lack of the list can look, very long, and that can be a little discouraging and create pressure that I didn't really want in the first place.
I'm going to ask you about COVID, but you did, mention that. So I will ask about it. Were you working during COVID at the center?
So I was actually in my intern year in California. So for every residency, we all go through an internship, which is general medicine, before we start our specialty. And so for us, ours is separated from diagnostic radiology residency. It's a year completely separate. And I was actually working in the ICU a lot of times during the peak of COVID. The big second peak that we had during Thanksgiving in 2021 was when I was working in the ICU.
Got you. As we all know, everything is like a nervous system. So I'm thinking that the radiation radiologist thing is also nervous system, and you have to, keep nourishing it for it to work
Yeah,
well,
absolutely.
right?
Absolutely.
So how flexible do you think is your management or the people who make decisions flexible in taking feedback and acting on it? Can you share some insights into that?
I can share some from a resident's perspective. I think as residents, we have a great advocate. Our program director always listens to feedback and advocates for her residents. A notable example is we acquired a new facility, a whole new hospital actually under the UW banner, and Northwest Hospital.
Northwest Hospital. Okay.
Yeah. So that happened sometime around COVID or pre-COVID. And because they're a whole other hospital, they require their own staffing for the emergency scans that they do. And as we've progressed since the acquisition, more and more scans have been being acquired, and keeping up with the volume can be hard. And there was a question from the administrative department side as to whether residents could also cover that for call. And of course, as residents who already take a lot of call, we were not huge fans of it because that would contribute to more weekends that we have to work, more evenings and more night shifts. And when we voiced that to our program director, she definitely took our opinion and our side and advocated that instead of making residents work more, why don't we just hire more attendings and hire more radiologists to cover these hospitals? Because if the University of Washington chose to acquire a whole hospital, with that comes more staffing that is required, not using trainees who don't get paid very much and work a lot as labor. That is obviously something that a facility, a hospital benefits from, right? They make more money off of us. They're getting a stipend from the federal government to pay and to train us, but it covers medical malpractice. It covers our salaries. So these are some of the things where there are inbuilt systems where our feedback has been heard. The one qualm I have with a system like an academic system as big as the University of Washington is because it's so big, making change is hard. It's not a small facility or just a small group of people where making changes can be a matter of days. If you want to really make the lasting impact for everything that we try to change on from a radiologist perspective, can take weeks to months to actually be implemented.
Okay. That's not too bad. Weeks. I can wait for a week to make some change happen if that is going to be sustainable for the long term.
Yeah.
Right. I always think about the unusual cases, what could potentially go wrong. And I think there is some model, somebody called Nassim Nicholas talked about it. I'm not getting that exact word right now, but the question is, what's an unusual radiology case that you have encountered, and why was it unusual? And did you have success, or the organization have success in recognizing it's a new, it's an unusual case because they haven't encountered it before, but they had enough brain power to put on it and solve the problem. Anything that you can think of?
There is one example I can think of from this week where this patient, he's male and he has a type of leukemia that's localized to the skin. And then he also very rare, but also does have a history of breast cancer, which is very, very rare in men. And that was something that we were able to point out on a scan. When we scanned through the chest, we found a nodule, a soft tissue mass that was in his breast. And we did raise the concern for breast cancer. He got a mammogram, biopsy proven breast cancer. He's coming in with a new mass in his abdomen, and it seems to be tethering his bowel. And we don't know what the etiology of this is, but it was nice to be able to talk to surgeons, specifically surgeons who worked with cancer, and talk to them and brainstorm all these different conditions that it could be. Not only that, but we came up with a game plan to be able to biopsy it and try to find an answer with pathology. Still waiting to hear back about that. But the amazing thing about medicine is you will always find a case that you've never seen before. Medicine is truly unique in the fact that I've had attendings practicing for 30 or 40 years, and they always, always, always see something new. And that is what's amazing, is that you're just lifelong learning the whole time you're in this career, and you're always humbled by what you don't know.
Yeah, that's why it is both exciting, challenging, and very educational.
Yeah,
right?
Absolutely.
Maybe, I think a lot of people are familiar with House.
Yes.
So do you have somebody like House walking the halls from morning 8 to evening 8? Do you have somebody like that?
Krish, just on a side note, I used to watch House all the time. And after I started medicine, I cannot stand that show. It is so medically inaccurate. I cannot encourage you enough to stop watching that show because it's absolutely ridiculous. The abuse of radiologists on that show is absolutely insane.
Oh, really? I didn't recognize that.
Yes. Well, and he won't, because I thought he was a genius. And then I was like, why is he getting CTs on this patient over and over again? Within 12 hours, it makes no sense for a diagnosis that's been chronic. And one CT didn't show it and the other one did, and it makes no sense. If you want a good medical show to watch, I would say Scrubs is the most accurate. ER is a great show too. But getting back on track.
But you know what, Karishma? I think he's a recipe for what not to do, and also I think it makes for the ultimate goal for a TV show is to keep people hooked.
Yes,
hooked for a long time, whether it's accurate or not. And it is the disclaimer is don't make diagnosis based on happenings in the show, right? I think people don't make the technical guys, like the technical folks like you. Obviously, you're watching it, but you're also making some assessments on what I should not do.
Yes. Yeah, absolutely.
Yeah.
From your question, to go back to your question, do I know anyone like House? I would say some of the attendings at the University of Washington, some of them are really dedicated to their work and have been trained in an old medical training environment where residency and the day only ended when the work ended. I think with generational change, the work-life balance culture has come more into the hospital environment and radiology as well.
Yeah.
So I would say maybe some of the older attendings who are really passionate, but man, they live in the hospital. They live and breathe and eat and just love it being there. And I love my job and I love being in the hospital, but I also love my life outside of my career.
Yeah.
And I don't think House showed it perfectly. You cannot have a personal life and work as hard as he does, or be in the hospital living there without consequences.
Well said. So, I was thinking about the patient interactions, and one of the challenges is education of patients, right?
Yeah.
Are you in the situation where you have to talk directly to the patients?
I am in situations for some rotations. One of the most notable ones is breast radiology. So that is uniquely set up to be in a clinic. So patients are getting mammograms and then they're consulted by radiologists, especially when their scan is positive. We do the ultrasounds ourselves. So during that interaction, we actually go in physically, take an ultrasound probe and try to look for the finding with a different modality to make further diagnoses. I have been in situations where a patient comes in and is very anxious, and I have to tell them on the spot that they have newly diagnosed breast cancer. And those can be some really, really hard interactions that the more times you do it, it doesn't get better. It's still something that I bring home every day, something I think about a lot. So those interactions, there are some of them in radiology. They're not as extensive as some other specialties that are clinic driven. We're definitely more on the technical diagnostic aspect, where we do have full days where we're not interacting with patients. The great thing is you get to choose that for yourself if you want to be more hands-on and do procedures, or if it's something that you think you can do a little less of and just be a consultant for doctors.
Since 2000, the start of the internet era, folks have been arming themselves with lots of medical data, right? And recently, with the evolution of AI, there's been more data, but things like ChatGPT or Anthropic seem more authentic and are sure of themselves. And so people start trusting them. What happens? Have you been in a situation where your the results of the diagnosis with a patient that is in your facility, they use their acquired knowledge to keep asking more and more difficult questions, and they are like in a situation where they are like really hostile to you. So one, you recognize that they are getting their information from various sources, but how do we handle patients who are, say, partially informed, not practicing medical professionals? How have you been in positions where you've had to debate them? Any escalations from that?
Yeah, I think you kind of described it. You described it accurately. We've shifted from a paternalistic model of medicine where you address that for your doctor. The doctor will come to your house, and anything that the doctor tells you is what you have, is the diagnosis. Now, with the advent of the internet, information is more accessible, which is great, but can be an ordeal from the standpoint of a doctor. The best example of this, I think, was during the COVID pandemic, when there was a lot of misinformation and pseudoscience that was being spread through social media. And I think some of the most difficult interactions I had in the advent of misinformation was during the COVID pandemic, when there were rumors about ivermectin being curative, even though it's a horse pill that veterinarians use to cure parasites. People were overdosing on that. I think you want to align yourself with the patients as much as you can and have an understanding of where they're coming from. I think most reasonable patients will hear you out, will want to hear you out if they feel like their best interest is being thought of while you're speaking to them. There are certainly have been patients where I have entered a conversation and their mind has been made up.
Yeah.
And at that point, you have to dictate in writing and in person that you are, in your best medical opinion, you think this is it's diagnosis A, but the patient doesn't agree with you. Patients are definitely able to consult another doctor if they feel like they're not being heard. I think the best thing that a doctor can do is try to align themselves with the patients as much as possible. We're just as much of diagnosticians as we are psychologists and psychiatrists, because a lot of our conversations with patients can be mentally alleviating or mentally burdensome, and allowing some clarity to that can make a patient less anxious.
Right.
It can be hard, though. It's definitely challenging. There have been some situations where I've not successfully been able to get through with the patient, and it does feel like a lost cause, because I have gone through so much training, so much education, so many standardized tests, so many checks and balances that the internet doesn't have to go through and AI doesn't have to go through. There are so many checks about critical thinking and putting pieces together and being a physician. But the internet and people on social media, they don't have any of those checks and balances, but they're so charismatic that people just believe that. And I think it's I don't want to I think people have termed it war on medicine in a lot of ways. It's a new battle that we have to face as physicians. That we're not trying to be selfish. We're trying to do the best that we can for our patients, and most of us are here to help other people. And back in the old days, we didn't have pressure back, and now that we do, the physician burnout rate is increasing because we're facing all these questions coming from the people we're trying to help.
Is this a global phenomenon, or do you think this more US centric? This
yeah, it's a great question.
Awareness, this critique of doctors.
I think it's more prominent in the US.
Oh,
I have read about other medicine models in other countries. Japan is the most notable, where it's a very paternalistic environment there and still is to this day. So definitely more of a US centric problem.
I see. Based on your experience so far, which country or regional area would you say functions the best patients?
Oh, that's a tough question. I don't think I know enough about other medical facilities to answer that, to be honest. I have heard great things about Sweden and Norway and the socialized medicine.
Yeah.
But I think they can handle their populations because they're so small.
Yeah.
A place like Canada has a larger population and their socialized medicine has huge wait times. So I do think in terms of the amount of treatment that we have and the diagnostic accuracy, the United States and Europe still surpass a lot of other places, but we are expensive, which can be hard for patients.
Going back to the education of patients, do you feel that adequate resources are being put in hospitals, treatment centers to generate enough meaningful advice that patients can take home?
I don't think there is, no. I think I've had some conversations or I've diagnosed things where I feel like patients leave more confused than when they entered. There is a huge shortage of physicians and administration who can give resources to patients. I think cancer centers have some of the best resources, but then there are other hospitals where we diagnose things that are not oncology related, where I've spoken to patients and they just don't have a great grasp on what their condition is.
Right.
I think there can always be more patient education. We've changed towards a model where we have an electronic medical record system and we've inbuilt all these pre-written pamphlets,
right.
I would say, where you just put in a little short phrase and it populates these words and sentences that's supposed to describe the condition to a patient. We've had some programs here at the University of Washington and even at my medical school where we've had radiologists specifically FaceTime patients to discuss imaging findings and have found that it really impacts the patient's understanding of their condition, how serious the condition is, and what they can do from a lifestyle perspective can impact the way that their chronic disease progresses. So if they have a better understanding of what their diagnosis is and what it's doing to their body and hearing it from somebody who really knows what they're talking about, like a radiologist who sees these findings that indicates that, the diabetes is getting worse and worse over time, then if a patient understands how serious it is and what they're seeing, has dynamic visualization of the body and what a normal looks like versus an abnormal finding looks like, then they have found that patients have done better in managing those chronic conditions.
So do you feel that, you mentioned AI a lot. I was not going to dwell on AI because, that's almost becoming a cliche for, everything under discussion right now. But very specific question. Do you feel that tools like ChatGPT, Anthropic, everybody would say, go to WebMD and find information, or go to Google it and find information. But I feel like the tide has shifted and people want to go to ChatGPT because most of the time it's free. Do you feel that is actually helping or not helping with this patient education?
I think on a basic level, it has a potential to help people. I think the fact that it's a little more dynamic compared to Googling phrases can enable patients to interact with AI and answer more clarifying questions. But again, I have some cautions with it for people who are subspecialized, like me as a radiologist. There have been things that ChatGPT has told me that is wrong, medically wrong. And I learned through an AI lecture actually that you can ask ChatGPT or any of these interfaces to double check the resources, so the sources that they're using, or double check what they're quoting, and they can correct themselves that way. So if you point out an error, you can tell them to correct themselves. But if you don't know what mistakes to look out for in the first place, then
Right.
that is spreading more misinformation. There are biases within every AI model that we just don't understand. There are ways that AI can hallucinate that we don't quite understand. So it's a new technology that I think is changing the way that we learn, as you said, and can be a great tool for us if we harness it the right way. Or it can be detrimental and can lead to more disinformation. I think that's all has to be determined.
Right. On that note, right, I've been hallucinating that my recent headache is not real. It's fictional. Okay. So the question really is, I mean, you observed that it could be misleading, but the question I have for you is, when this whole medical enhancements to, AI enhancements to radiology, I noticed that, many people in Silicon Valley keep talking about how radiologists will be replaced because, AI can do a better job. So, talk to me about, how extensive is the use of radiology in your workplace, whether you use it to consult on every case or only on complex cases, and if you have had any recent success in generative AI to, solve or give you more insight on a problem.
Yeah, that's a great question. And I get this question a lot. We actually do use some AI in our workplace. And I think AI is a tool that can enhance our ability to be better radiologists. One way that we use AI is to find acute things like stroke, a head bleed, a blood clot in the lung. These are just some of the many things that we have artificial intelligence helping us with. I will say it's not always accurate. So you have to go in when AI is telling you something is positive, you have to go in with a certain level of doubt or questioning as to whether or not something is a real finding. And on the other hand of AI Doc, which is the program that we use, whether that AI is flagging a study as negative when there actually is an acute finding. The one thing that it really does help us with is we have a lot of scans come into our facility. We have many different hospitals, inpatient and outpatient facilities. And when you're on call or when you have a big list, it helps prioritize our list. So if there is a positive finding, AI can bump that study to the top of our list or flag that so that we look at it earlier so that there's no delay in patient care. So this is one of the many ways that AI enhances our ability to be better clinicians and better radiologists. As we're growing as a facility, as a field of medicine, AI is also growing. And the best way that we can address this growth is to adapt it. So not be scared of this technology, but to try to adapt it into our workplace and use it as a tool for us to be better at our jobs.
Gotcha.
As I said before, I've had attendings who worked on a light box with, radiographs on actual films. So they've gone from that to a high power PAC system where we have everything in a centralized system and we have images pushed to us that we can dynamically window and come up with diagnoses. So we've made that jump already as a specialty in medicine. Now we just have another tool, another technology And the best thing we can do is adapt it into our everyday lives and our everyday workflow. Because I do think it has the ability to just make us better at what we do.
That's great to hear. But I also have a potential, caution is that if you become too dependent on it, because when there is something that, is in your radar all the time during the day, you could sometimes say, okay, I will overlook this. The AI is probably right?
Yes.
It's because people are busy, as you said.
Yes.
And, the pressure of being busy sometimes, leads you to take shortcuts. While AI is a great tool, have you seen cases where the AI is like diametrically opposite to what you as a radiologist would do in the same situation? And if there has been any side effect of following the AI's guidelines verbatim?
I see it on a daily basis, just to be frank. I've had one of the best examples is the overstimulation or the overuse of AI, where the more tools you implement into detecting something, the more flags you get on your list, and the more red flags you have, the less urgent something becomes in your mind, right? So if you have a list of 100 scans and 90 of them are red, how do you prioritize which one to look at first if the AI system thinks that there is something that needs to be addressed right away?
Right.
And a lot of those, I would say, out of 90 of them, I would say only 5 or 10 of them have something that needs to be read at this moment that would change a patient's care. And so I agree with you. We have to use this technology with caution because there's overstimulation, which I think is a huge concern right now at this moment. And there have been cases where they didn't flag it. And I'm not sure why. The technology is flawed. And if we rely on it too much, we wouldn't be able to notice something that is life-changing, like a stroke or an aneurysm or giant blood clot. So the old-timer radiologists, my attendings, who have been in this for generations, have always urged me as a trainee to be cautious and approach every scan with the level of acknowledgement of the AI, but also come in with my own impressions, come in without a bias, because that would make me better at what I do.
Right.
But there is one instance where my attending found that the algorithms that they were using, which implements AI, started hallucinating masses in the lungs that weren't actually there. So, and because he took the time to sit and figure out this, because the patient had clean lungs until GE updated their system and has a certain algorithm that they restitched the lungs into, and it started creating all these little nodules. It was only because he looked at that closely and tracked the patient over time that he was able to give feedback to the company and tell them that whatever algorithm they're using is hallucinating.
Okay. In that instance, did temporarily pause? Or they're like, we are not anyway not going to follow to the letter, but at least, let it be a tool that can sit aside and, we will not face any issues.
What's funny is that legally, these companies are not required to tell you when they're changing their algorithms. So, you've got their machine and then you've got software updates. And most iPhones will tell you when there's a new software update and if you agree to uploading it.
Right.
A lot of these medical facility companies don't have to tell you when they're tweaking an algorithm and what the consequences of that can be. So a lot of times you're not even aware when these changes are happening. And it is faster to adapt your practice than it is for a giant company to make these changes or try to come to the root cause. So the funny thing is that AI has simplified some things, but has also created its own unique problems. And we have in the back of our mind a list of things to keep an eye out for because of these problems that have come with the use of this technology.
So it's a caveat emptor scenario, right?
Yeah.
And the customer beware. Hey, Karishma, it's time for some, simple questions.
Okay.
Okay. So, what is your favorite sport?
My favorite sport that I like to watch would probably be soccer. And I grew up swimming. So I would say swimming is something that I like to do, especially out in the open ocean.
Nice, very nice. I loved our conversation. I think we will connect once again, in many months to see what you're up to. And I wish you the best of luck in your boards.
Thank you.
I think it's going to be a cool thing. So before we leave, do you want to say something else? Like, did I leave anything that could be very interesting for our listeners?
I think this has been a really great conversation. I hope that whoever is thinking about pursuing a career in medicine, especially radiology, really considers it seriously. I think it's a great career. It's a great path to creating a lot of great opportunities to impact other people's lives. And of course, I think it's a career that gives you a good work-life balance, being able to have a personal life, time for family, friends, hobbies is something we like to talk about in the reading room at work. So I hope I brought across how much I love my job and how much I can be a balanced person, even with the career that I have. And I think if anyone has any questions, feel free to reach out to me.
Okay. On the work-life balance, I need to disagree a little bit because my daughter is a veterinarian and my son-in-law is a plastic surgeon. So I don't see them having a work-life balance. Maybe I don't know, but the jury is still out on that, I think.
Yeah.
Okay.
Yeah, that's fair. Absolutely. I think they have very demanding jobs. Very surgery and veterinary care are some of the hardest careers to pick.
All right. It's been wonderful talking to you. Have a great weekend. It's coming up.
Yeah.
And next time you want to reach out and share more insights, please do. And I'll always find time to accommodate you in my podcast.
Thank you so much, Krish. I really enjoyed our conversations.
Thank you. See you around.
See you.
Thanks to you for tuning in. We always like to hear feedback from you. You can tweet to us at Carabiner Media 1. That is Carabiner Media and the number 1. You can also send us email at startupfeedback@carabinermedia.com. We hope you share this podcast with your friends and colleagues and also rate us in your favorite podcast platform. See you next time.